Okay, we're streaming now, Chair.
Okay, good morning everyone and welcome to the Adult Social Care and Services Scrutiny Panel January meeting. Today we have Eric Scully, Director of Adult Social Care and Health Integration, Katie McLeod, Head of Commissioning and Strategy for Tees Valley Clinical Group, and Catherine Warnick, Programme Manager of South Tees Integration of Health and Social Care. We also have David Smith from Teesside Hospice, who was just listening in. We're going to the agenda. Have we any apologies for absence?
None received, Chair, all present.
None, thank you. Any declarations of interest? No, thank you. Right, the minutes of the last meeting are going to be held over until our February meeting and they will follow then. And then we're going to we're going to item 5, which is Eric Scully. Eric's going to make a short presentation. Over to you, Eric.
I think what I shall do, Chair, is just talk briefly with an update on health and social care integration work, and really it's these updates continue to be different from the form that they took, I think, pre-COVID, if you like, because the bulk of the work that's going on at the moment by staff within adult social care and public health is absolutely in relation to response to the ongoing COVID pandemic. And I think we've had various bites at understanding what recovery work might be around this, and we've got a kind of framework for that. But it feels very much at the moment with the position that we're in nationally and the delivery of vaccine on the horizon, that we're still very much in this. So everything for me is about COVID response at the moment, and for our staff group. I think that I've been receiving lots and lots of questions over the last few days, really about vaccination, and it would be fair to say the bulk of my time is taken up now in discussions and planning around vaccination. Now, vaccination is a responsibility for the NHS rather than the local authority. But actually, because we commission lots of the services where very vulnerable people live, and also because we have a large number of staff within the kind of the top 4 priority groups that the Prime Minister and Health Secretary have said we would aim to vaccinate by the middle of February, then there's lots of preparatory work for us to do. And certainly we're working very closely with the NHS in the form of the local clinical commissioning group and the local acute hospital primary care networks to make sure that we've got plans in place to support them with getting staff through the system. So I'm delighted to say that we've started now to feed social care frontline staff members into the vaccination programme. That's really started at James Cook this week. For some time now, obviously, we've been supporting the acute hospital to vaccinate care home staff members. They've been working through the larger care home staff groups, and now that's in the process of sort of rolling out to primary care networks, delivering vaccine to over 80s and to the care home residents. So I expect that we will see the pace of vaccination accelerate radically over the next week or two. It feels, I guess, from the outside looking in, it probably feels a bit chaotic and a bit scrappy in places. And I think there's a degree of inevitability about that, simply because of the scale of the operation, the complexity of the supply chains and the management of the different forms of the vaccine. So it's by necessity, because the original vaccine was so sensitive to handling. The Pfizer vaccine came in these big trays, had to be kept super cold, and the cold chain had to be assured and whatnot. I think there was a compromise between the individuals who had the highest level of need and the sheer practicality of the logistics. So the NHS recognised, or the government recognised quickly, that really the only people that were going to be able to handle these large trays were probably the acute hospitals. They had the facilities. And where it was easy to bring care home staff into the acute hospital for vaccination, it was much less easy to bring in vulnerable care home residents. So the vulnerable individuals who received, in the first instance, those vaccines from the hospitals were kind of restricted to outpatients who were over 80, hospital discharges who were over 80, as well as the kind of the professional staff. But actually, with the AstraZeneca, the Oxford vaccine materialising now, we're starting to see things change, and like I say, it will accelerate. So that's the bulk of my time at the moment is dealt with that. That's the kind of the absolute well, I was going to say the absolute priority. That's a shared priority alongside keeping our services running, and that, you know, although I talk about adult social care services, everything is done in conjunction with the NHS, either through the CCG or through the acute hospital or through Tees and Wear Valley or local mental health trust. So we're very, very busy keeping the wheels on. But it would be fair to say that we are probably seeing a greater fragility in our social care services at the moment than we have done during the first peaks of the virus, because we've got sort of more people isolating, more people involved in test and trace, taken out or flagged and taken out through that. So I think we're going to have a busy time, and the acute hospitals, the NHS, are under sustained and acute pressure at the moment. There is no question about that, and we have not yet seen the peak of the pressure that will materialise from the relaxation of guidelines over Christmas. We're still probably a week to 2 weeks away from that, and the hospital is under acute pressure, as are our services. So I think we're in for a bit of a bumpy time. I'm reasonably comfortable as you might expect to be in a global pandemic, with where our adult social care services are and our flexibility to respond to that. Staff have been fabulous in their, like I say, their flexibility and resilience. So I think it has never been more important that people abide by the guidelines now. The hands, face, space stuff, the stay home, protect the NHS, the minimise social contact, all that stuff has never been more important. And we are going to have to run with that for a while, because vaccinating people will not be a panacea. It does not mean that everything will go back to normal once people have had the vaccine, because there are still all sorts of questions about how long the protection the vaccine provides is sustained for. And potentially the bigger question is that about your ability to infect others once you've had the vaccine. It might protect you from having serious illness, but it doesn't necessarily protect you from infecting others. So the masks and the social distancing and the simple messaging, we're going to have to live with that for some time to come. However, I think 2021 is going to be a much better year than 2020. And that's probably all I need to say about health and social care integration. I'm hoping that normal service will be resumed soon, but at the moment, it's all hands on deck for the pandemic response. I'm happy to take any questions on that.
Okay, thanks, sir. I just one question. I'm sure I will have loads of questions. Have we had anybody in the care homes vaccinated yet?
Absolutely. We absolutely have. The primary care networks are working through care home residents, so the kind of GPs have got their list of over 80s and vulnerable people in care homes. They're working through those lists. Anyone who's been in hospital is coming out to care home over 80 is getting vaccinated. So yes, that work is going on, and obviously all of our care home residents. I mean, there's various statements come out from government in terms of the plan, and the plan evolves, by the day, and I don't see that as a problem. I think I've seen, we've spent an awful lot of time planning things that haven't quite been delivered or haven't quite been implemented sort of centrally in the way that they were originally set out. And at times that's felt frustrating, because you put a load of planning effort in and then it doesn't quite materialize. But with the benefit of a little bit of hindsight, what we see is usually the next iteration of the national plan is a bit more mature and a bit more developed. And we're learning from the previous planning, if you like. So we're building the response, we're growing the response nationally and locally as we go along. So things keep changing, but the government, certainly the health secretary has said and has repeated that the intention is that all of those first four priority groups, which includes all care home residents, all over 80s, 75 to 79-year-olds who are clinically extremely vulnerable. I'm going to get this wrong, so don't quote me on it at the moment. But the top four priority groups, which includes all the health and social care workers, will be vaccinated, by the end of February. So the care homes are well on the way to that.
Are you confident that you have enough vaccinations to do all of this?
Am I confident I have enough vaccinations? Well, I don't know. My colleagues in the NHS tell me yes. The reason I'm hesitant is that because there are so many routes by which individuals are getting vaccinated, I don't have access to a central data set, Chair, that shows me the how, you know, how far we're through, what percentage of the way through the numbers, the overall numbers we are. So I don't get a clear sense of progress. I know that, you know, I will be able to see the speed at which we're passing social care workers into the system, but actually I get no overall sense of how far through, other than that which can be provided to me by the NHS. And the numbers, sorry, I'm rambling here. I think basically the NHS controls the data set, and it's not being shared with local authorities at the moment, despite the fact that we've asked for that, Chair. So in terms of confidence, I don't really have a way of calibrating that at the moment. I think it'll become much clearer over the next week or two. I mean, I think we're probably nationally, what we heard on the radio this morning, so it's probably not. I heard on the radio vaccinating nationally, I think about 500,000 a week or thereabouts, and I think to make the target by the point in February that's been identified, we probably need to multiply that by 5 times. So it depends how quickly the system grows over the next week or two, Chair. I think if you ask me that in a couple of weeks, I might have a slightly less rambly, clearer answer.
Okay, sorry, I just had to ask you.
That's all right. I like more questions.
It was I just had some information from a briefing yesterday, Chair, that there's 6,500 James Cook staff's been vaccinated to date. Around 12,000 residents, vulnerable residents, including care homes, staff, and over 80s, have been vaccinated across Redcar and Middlesbrough. I don't know the breakdown across the 2 local authority patches, but so if you half it, it's around 6,000 residents, care home staff, and over 80s. As of yesterday, that was, Chair. I don't think Katie's got anything more up to date.
That's brilliant, Catherine. Thank you. Graham wants to come in.
I think you're on mute, Councillor.
Sorry about that. I had an email from Dr. Nanda. Don't ask me to pronounce his other name. There's the start roll out the process on Thorntree Estate this Friday coming with the vaccination process for the over 70s. Start Friday, then I think going Friday, Saturday, Sunday, and hopefully finish it on Monday. I don't know where that would take us in Brambles Farm or the rest of the ward, but that's only good news at the moment, I would think. Thank you, Chair.
Okay, thank you. Donna wants to come in.
Can I just ask, housebound people for the vaccination? Because my dad's housebound, and yesterday I got a call off his GP for me to take him to Thorntree, Beresford's Buildings on Monday for his vaccination. And I said to her, he's housebound, and she just said, well, you're going to have to wrap him up and put him in a wheelchair, because they don't know when the housebound vulnerable people are going to be vaccinated. Is any news on that, or do you know anything about it?
I don't have a so I don't have a specific sort of answer on that. I mean, other than my blanket answer that this is being implemented so quickly that on a kind of daily basis, the NHS planners are going to be tripping over issues just like that. And where one day there isn't an answer, 3 or 4 days later, someone will have gone away, recognised the problem, and come up with some form of response to it. So I don't know. I mean, I obviously know that there are some people who are housebound that you can wrap in a blanket and put in a wheelchair. I'm not commenting on the desirability or otherwise of that. But there are some people where that's just not possible, where that's just not practical. And that will be a reasonably large number of individuals, you know, if not in Middlesbrough, then in the northeast or nationally. So there will have to be an answer to that as a problem. I know that the health secretary the other day, he mentioned mobile vaccination centres or units when he gave his press conference a couple of days ago. And I don't have any information on that. I don't know whether that's a reflection of the need to go door to door. But I imagine that there will be conversations going on between the NHS and the primary care networks, the GPs, about what their response is going to be to individuals on their list who are vulnerable, need a vaccination, and can't get out of the house. I mean, I don't know the answer, but it will have to be cracked because it will be a bigger problem than just your dad, Councillor Jones.
Yeah, because she just said it's porta cabins at Beresford Building, and that what my concern was, because he's COPD, he's 87. Like, how long will there be a queue? How long is he going to be outside in the cold for? And she just said, make sure he's wrapped up well.
Yeah, I mean, we can't have an individual with COPD who's older and vulnerable sat outside in the cold and the wet, waiting for vaccination. That is self-defeating. And I think we've already had one example, which I've discussed with the chair of the CCG, accountable officer that CCG raised at the strategic coordinating group last week, where they had recognised that one of the early vaccination centres they had to queue outside, and that had been sort of unfortunate, and we're working hard to avoid having that again, because we need to avoid making people more vulnerable in the process of getting them to the vaccination site.
Thank you.
Okay, Donna. Okay, Geraldine.
Yes, regarding the surgery at Beresford Buildings, it's set up. The porta cabin in front of the surgery is for when they've had the vaccination and they have to wait for 15 minutes, so there's no reaction. The porta cabin is for when they've gone through the surgery and they're sitting having a cup of tea until the host says they're allowed to pass on. But yes, the surgery I go to as well, I haven't had my vaccination yet. I go to get my leg dressed, but now, because of this, I have to get up to One Life to get my leg dressed twice a week. So again, there's other facilities to go to. But I think the nurses were saying, the staff there, it's incorporating about 7 other surgeries for them to go to Thorntree surgery. But at the moment, the nurses are saying it is proving very good, but they haven't actually started doing the vaccinations yet till Friday. Thank you.
Thank you, Geraldine. Graham, you wanted to come in?
Yeah, I think I've got a phone number for the Thorntree surgery, Donna. If you want to check it down, try and check on it, but I can do it myself and give you a ring back. But yeah. Give me 2 minutes, Chair. I'll just make this phone call for Donna.
Okay, Jeanette.
Just on that score, I mean, I think we have been advised not to contact our surgeries. Am I correct on that? About any vaccination. So I think perhaps, that will increases the pressure on our own doctors. And I do feel a little bit concerned about maybe phoning them about anything to do with the vaccinations at present. I know it's difficult, and there are going to be logistical difficulties right across the country with this. And I think we've got to accept that there are some people that are going to, we are going to struggle, and this country will struggle, and it has been struggling, because I know that for a fact. I mean, we're struggling to get people the second vaccine, aren't we, as well? So, the second shot, and the longer between each one is not being actually addressed. So hopefully that this is going to, eventually get sorted out. But I mean, I know they've got the military involved in the mass testing, the mass vaccination points now. So they're being taken over the strategic and logistics of getting people in there and out again. So and that's right across the country. However, I don't know whether they're going to be involved in Middlesbrough. I know they're in Newcastle and Birmingham, but I don't know where else. So don't phone your surgery. I think it's going to just increase the pressure on them at the moment. So maybe.
Yeah, I must admit, I waited for my dad's surgery to contact me, because I did get a text saying, we're overwhelmed with all phone calls, so not to phone. So I just did, like I say, they rang me yesterday. Where he's going isn't his surgeries, isn't Cleveland Centre, so where Graham's phoning, I don't know.
Okay, thank you. Any other questions for Eric? No. Okay, Eric, thank you very much. And we'll move on now. Is it Kitty or Catherine or doing a short talk?
Chair, apologies for interrupting there. I don't know whether you would like to take the next item on LGBT update, just so that Eric can obviously finish his item and leave the meeting, if that's okay, Chair.
Okay, my apologies. Eric, you're still on.
It's quite all right, Chair. Thank you, Susie. You got my back this morning. That's lovely.
Thank you, Eric.
So I just want to give you all a brief update as requested on the LGBT Community and Elderly Care Action Plan, which is quite an old action plan. It dates from a point during 2019, and it relates to a scrutiny investigation which was looking at issues. It arose primarily because of an observation that issues around LGBT really figured very little in conversations around care homes. And there was a view at the time, and there was some work done by the mayor at the time about contacting our care homes to I think really it was looking at the quality of the environment that was there, whether individuals who would self-identify as lesbian or gay or bisexual were comfortable expressing that sense of identity within the care home setting, or whether or not there were obstacles to that. So there's a piece of scrutiny work done, and then some actions initiated on the back of that. And some of those, I mean, not all of the actions, I guess are complete, but I suppose the observation I would make is that this is not something that you can do at a point in time and then sort of forget about. It has to be something which you come back and revisit and return to. It has to become part of ongoing work, and I think to some extent we've managed to make it that. So I'll whiz through the action plan, which I know was provided late, but I think it's quite straightforward, and people have probably had an opportunity to have a quick look at that. So looking at the first item on there, it was about activities that raise awareness and celebrate LGBT identities be undertaken in care settings to encourage participation in open discussion. So I think what we found when we spoke to the care homes was that the care home, there were very few individuals. We wrote to care homes across Middlesbrough, or the mayor at the time wrote to care homes across Middlesbrough, asking for assurance from managers that these were issues that were kind of taken into account. And it was really, really obvious that there were very few individuals who identified openly as being gay or bisexual within that care home setting. And we didn't really have a sufficient richness of information to know whether or not that was because people felt there were barriers to expressing openly their identity, or whether or not, given the age of the individuals there, we still had a cohort of individuals who'd grown up when, to be openly gay was much more controversial than it might be seen as today, and so individuals opted not to. And I think the response that we got from managers was very much about, we're not really sure the extent to which we want you to push this in our care home, because we feel we've got good relationships with the individuals who are in here. And if people want to express things to us, we know people who are gay in our care homes or bisexual or whatever, but we don't want to push too hard on this. So I think what we have to recognise that care homes are individual businesses, and we have some degree of control over how they operate through our contracts and commissioning process, but there are limits to that. So what we did was we have a regular care homes forum. And there have been discussions around these issues at that care homes forum to kind of keep it on the plot. But this is one that we will continue to return to, but we'll fundamentally leave with the care home providers themselves. The second action was to do with training and development sessions, and it relates to a further action down here that was about work to be taken by officers in contracts and commissioning within the council around these issues. Really what we need to do, and what I think we have done, is make sure that in the training that is provided to independent providers staff, and in our monitoring of that undertaken by our contracts and commissioning staff, we make sure that all issues related to equality and diversity are satisfactorily addressed, including LGBT issues. And that's something that we have now built into, well, it was built in, but we've strengthened it within our contracts, that we need to see the policies that relate to that, and we need to be confident that appropriate training around equality and diversity issues are present and mandatory for all of the staff in the care homes. And we're now operating at a level where we can see that and we can demonstrate that is there. The monitoring visits that our contracts officers undertake also involves conversations with staff members, with residents in care homes. So we have a view from that side by which to triangulate. And although the contracts and commissioning officers don't speak to individual residents on a very frequent basis, our care home residents are also reviewed by our social workers. So we do have touch points through the year where social workers are in and talking to residents. So we've got a number of means by which to identify if there's a discrepancy between the lived experience of the part of the residents and the policies and training that are in place. We looked at, there was a request for an online LGBT awareness raising module. We've built an enhanced LGBT element into the equality and diversity training that we now have in both our corporate induction and in our equality and diversity training, which we have online for our staff, which is on the Middlesbrough Learns platform, which all elected members have access to. And certainly we monitor the uptake of that for our staff, because it certainly within adult social care it's part of their mandatory training. So we've built that into it. The next action on the update was around the abbreviation. It says acronym, but really it's an abbreviation, Lgbt. Now the significance of this is it's reasonably complicated, that in different settings you will find different ways of abbreviating the set of identities around issues to do with sexuality and gender identity. So I think some organisations you will see it described of as LGBT, some you'll see LGBT plus, some LGBT and Q, and there are some sort of abbreviations where there are multiple letters representing multiple identities. And in each instance, there will always be a group of individuals that feels it's important that there is prominence given to one element over another, or certain elements over others. The significance here of the LGB and T versus LGBT is that there is a strong voice from individuals who would identify as transgender or who are transgender, that the LGB parts are to do with sexual identity, whereas the transgender part, the T bit, is to do with gender. And they would argue that is markedly, those things are markedly different. So actually, when we discussed the use of LGB and T, it actually brought recognition in the national news media that Middlesbrough Council had said and T rather than just LGBT. There were other voices in that national discussion that were arguing against the use of that. So I think the conclusion I came to is that there will always be a degree of controversy around the way in which we abbreviate this. There's no question about that. There's always going to be someone that tells you got it wrong. And actually, it would be wrong to get, from my perspective, I think it would be wrong of us to get bogged down in the abbreviation and spend too much time on how we abbreviate it rather than doing something about some of the issues that underlie it. So I mean, I've quite comfortably, I went to the Equality and Inclusion group that I chair within the council and spoke about this, and we've been quite happy to use the LGB and T element, because I can see the argument in that. Whether or not as an authority we decide to change that over time, I mean, we might revisit that, I don't know. I certainly won't be rushing to do it, so I'm quite happy to use LGB and T, but I confess I equally revert to LGBT, for instance. So I wouldn't want to spend, I have spent time trying to describe that, but I wouldn't want to spend too much time on that. The next action was about engagement work be taken with communities, and I think that I've got this marked as complete, but I'm least comfortable about this in a way. We met with the then Director of Culture, Communities and Communications, no longer with the organisation, and there were some actions undertaken there to build issues to do with LGBT into the work going on within that directorate, which has much of the contact with communities across the town, and that would become part of the sort of the cohesion work as an organisation we undertake. That was picked up and is being worked with, but I think that is one of the issues that if we're going to come back to anything, or I think really if you ask me for a further update on anything, that would be one of the issues that I would want to come back to, just to try and identify the extent to which, rather than simply saying yes we're doing it, the extent to which we're actually achieving something by that. So I think it would be appropriate to come back to that, and that's certainly one of those issues that you can never really in time just tick it off, because there's always going to be more that you're going to do tomorrow and do the next month and do the year after that as our communities change within the town. The bit that is outstanding is the briefing. The briefing for elected members, which was intended, I think, to be delivered as a series of a series of briefings. That piece of work got delayed, and I think has just sat parked certainly throughout the COVID period, and was probably overdue before that. So I think I'll undertake to make sure that we crack that within the first quarter of this year, because that action is outstanding, and for that I apologise. And then there is an issue here about partnership, working with other organisations, and I think the council in all its kind of commission work or contact with the voluntary sector and the rest, we've continued to work alongside a number of organisations who identify issues of LGBT as central to what they do, but also in the way that we work with commissioned agencies. We require them to have the same level of evidence that they are considering quality and diversity issues in everything that they do. So it is something that's on the radar through our commissioning processes. And then the final issue here was to be an action undertaken by health scrutiny. So as is sometimes the case with scrutiny panels, there's a piece of work gets passed to one of the other scrutiny panels because it sits with their remit, and I think that's where I cease to have a view or an understanding of it, but an update has been circulated to you. So I'm happy to take any questions on that, and I'm happy to be directed to do further work on any of the elements of it if the panel feels that's appropriate.
Yeah, thank you, Eric. Difficult subject and a sensitive one. Has anybody any questions for Eric on that? Jeanette?
I was part of that. Good morning. Thank you, Chair. Yes, Eric, I was part of that scrutiny actually that looked into this, and I think we examined it really quite fully. And we got lots of people coming in to give us evidence, and Stainton Care Home was one of them. The people from there, the Gables, we had Age UK, Age UK Teesside, the LGBT Anthony Towers, I think it was, LGBT development worker, and we had lots of these people in, which gave us a really good basic outline of what was going on in the communities. And I think one of the reasons we actually took up the scrutiny was because there was question regarding anybody of any of those LGBT issues that they were going into care homes, but were frightened to basically say that they weren't just they wanted to keep on the down low, so basically because they wanted to stay hidden, because they were frightened of any issues that might come forward from either care workers or other residents in the care homes. And I think that was quite sad really, that some people felt that they weren't able to just say who they were and be proud of who they were, no matter what age. You know, I mean, we all get older, but I think as time was going on, one of the things we were worried about as well was the fact that, and I think that was highlighted by Ellie Lowther, who actually came. She's the trans instructor, and she's brilliant. But she said, you know, as time goes on, more people are less afraid, more people identify in one way or another, LGB, anti, and Q, etc., etc. And I think there's lots, as you quite rightly said. And as time goes on, then it's going to be more acceptable to be part of this wider community, which we are. And there are still areas of concern where people are they misunderstand things and also tend to target or bully or even make people's lives very difficult. And I think as long as we ensure that, and I think that's why we took up the scrutiny, we want to ensure that that wouldn't happen in the future. There wasn't any specific evidence of that, but there was obviously stories and gossip, etc. So we hope that that wasn't in any of our care homes, but there was nothing identified as such. But I think we actually had a pretty good scrutiny, and all those recommendations I think were correct. I think, Eric, with the way things have gone this past year, that everything seems to have just gone all over the place, and we're all trying to do catch up now to make sure that we haven't lost anything that's so important to our communities. I mean, there's still issues now where people are in their own homes and still feeling afraid to identify who they are, and I think we've got to keep that in mind too. So I just wanted to point out that it was a really instructive piece of scrutiny and very, very good part of our work.
It was a very in-depth piece of work, no question about it, and we learned a lot for it. There's no question that people are still, disadvantaged and discriminated against in our communities for a whole range of reasons, including those that were the subject of the scrutiny. And it's absolutely paramount for us that we don't get replications of that discrimination and disadvantaged in care homes where people are living in an institution, however supportive that institution is. Absolutely.
Okay, thank you, Gina. Anybody any questions for Eric? No, thank you for that, Eric.
Thank you, Chair. Well, with your permission, then I shall duck out and go back to COVID response. Thank you, folks.
Okay, then move on, and we'll come to Katie.
Thank you,
You're
Chair.
on, Katie.
Thank you. I circulated a couple of presentation slides to you. Is it okay to show them? Because it might just help share some of the detail.
Sorry, I do apologise.
Yes.
On mute. Yeah, that's no problem. I've got the presentation ready. I'll share it now for you, Katie.
Thank you very much. Thank you for inviting me along today, everybody. Craig Blair from the CCG came to present last time. I'm conscious that I probably haven't met a lot of you before, so just while Susie is bringing it up, I'll just do a quick introduction. I'm Katie McLeod, I'm Head of Commissioning here at the CCG. I support the adult 18 to 64 age range agenda, which covers a whole range of acute and community services, lots of work around long-term condition management, cancer services, and as you can see, end-of-life care. So this presentation really is just to build upon the information that was shared at the last meeting, and I suppose to focus on the future of the programme and to give you some further information around where we are right now and hopefully answer any questions that you may have. So okay, if we move on to the next slide, thank you. So just really to recap, and this is what a slide that Craig shared last time, more so to set the scene really for members, and just to reiterate our overarching aim of the CCG and partners, just with regards to palliative care and end-of-life care, what we hope that our vision will turn into, which is very much focused around the experience of the patient and all of us working collectively to make sure that patients can access consistent and supportive services across our locality area. Next slide, please, Susie, if that's okay. Thank you. So I think, as Craig touched upon last time, as a Tees Valley, we've been selected as one of 4 sites to be classed as a commissioning exemplar site. So we applied through a process with NHS England to be one of these sites. And the idea of the programme is that it means that NHS England will support us to engage with our partners and engage with the public to better understand our current services, people's thoughts and experiences of end-of-life and palliative care services, and to use this information to help shape a vision for us and for our localities moving forward across the Tees Valley. And I suppose where we're thinking of from a Tees Valley perspective is there's hopefully an opportunity for us to think about that as a high-level vision, but then really work into that detail underneath within each of our 5 localities around what does that mean for each area, so we can really make our services place-based and to meet the needs of our localities, but hopefully we can build on a cohesive vision. So as part of the programme and being one of these exemplar sites, we've got an opportunity to utilise some funding they've provided and their support to build this vision. And I suppose the what's in it for them, if you like, is an opportunity for us to test out some new contractual models, to help give them some feedback on some new service specification ideas, and to really work in collaboration with them to help them build their knowledge around palliative and end-of-life care services and utilise that national expertise to really help us drive forward the agenda. The timescales for this piece of work are that it should take place between now and March 22. So hopefully over the course of the next year, we'll be able to undertake some really meaningful engagement processes, pull together what we feel that our vision is for our locality areas, and then start to work through some detailed actions to get us from where we are now to where we think that we need to be. Next slide, please, if that's okay. Thank you. Since we last attended, we've started to progress a number of actions. I'm conscious that it isn't long since we last came, but I'm hoping that this will give you a flavour of where we are and where we think our next steps need to be. So we're processing the framework that NHS England have sent over to us to allow us to start this work in partnership with them. It takes the form of a memorandum of understanding, and we're hoping to get that signed by the end of the month, which will then obviously release the funding that's made available to us to then really kickstart the programme. We've got plans to recruit a dedicated project support officer, and we're in the really early stages of getting that sorted out. We've joined some national groups that NHS England run that support the 4 exemplar sites to really work in close collaboration with NHS England and learn from them as much as they learn from us. And we're also developing a peer support network across the 4 sites. Again, just to support those conversations and build those relationships and learn as much as we can from every area around what's working well, how have things gone, can we learn anything, can we do anything better, and also to look at how we support our clinical leads and if there's any networks that might benefit them in terms of sharing information. We've started to scope what information we think might be useful in terms of some, I suppose, some thought-provoking questions that we could start to use as part of that early stage engagement, just to really help us better understand where we are now, what everyone's thoughts and experiences are of services as they stand now, and how we can then use that in our engagement sessions to then build upon where we need to get to. And we think that the National Ambitions Framework for End-of-Life Care is a useful tool for this. We've utilised it in the past, and you can undertake a self-assessment against it. So it's the national document that sets out 6 key ambitions and what's needed to realise each ambition, and the things around care being coordinated, seeing the person as an individual, the role that the community can play. And the idea is that if you can design services around these ambitions, then you can really hopefully get the best out of the services that you can make available and make the services the best for patients. Again, like I said, we've undertook a self-assessment in the past, and we'd like to revisit that, really just to help us set the scene around where we are and how we can move forward with this programme of work. We are mindful, and I think obviously it's been covered a lot in previous conversations today, around the current climate and how much pressure the system is under, and we really want to afford our partners the right opportunity to engage. So we're trying to be really mindful around when we really start to get into a lot of this detail. Equally, we don't want to put things off, and sometimes there's never a right time, but we think we're going to make some assessments over the next couple of weeks to see when starting engagement would be the most appropriate. But in the background, we're trying to get all the planning work done to get everything as ready as it can be. We're working with some external organisations to try and make sure we've got the best support for these engagement sessions, taking into consideration how we engage in the current climate and what platforms that we can use and what opportunities that we have, just to really make sure that we can make best use of the programme and hopefully get the best out of the opportunity moving forward for our locality areas. So there's only really those few slides just to give you an update, but I'm more than happy to take any questions if anybody's got any.
Okay, thank you, Katie. Anyone any questions for Katie? Jeanette?
Thank you, Chair. One of the things I was wondering, you mentioned about coordination. Is that between different services offering different things? Like the Macmillan nurses, all these different agencies who are involved in people's lives at some stage, or might be. So you're talking about coordination of their services to ensure that person gets what they need when they need it. Is that right?
Yeah, absolutely. So we're
Just
conscious
talking together.
Yeah, there's a range of providers that offer support across a patient's palliative and end-of-life journey, and that can be right from, you know, that's the kind of secondary care inpatient support right down to the voluntary sector. And we want to try and make sure that we offer as a cohesive service as possible, so patients don't have to repeat themselves on numerous occasions, that we find the best way to share information, and that we just find the best processes to support individuals. And you know, we know that it's not easy and we haven't cracked it in any service, but we really want to go through a process of co-design so we can talk to everybody, get individuals, organisations talking to each other. So now we've got this opportunity to hopefully try and reset and look at how we move forward, that we do it in the best possible way. But yeah, like you said, there are a number of organisations, and it's how do we ensure that everybody works together in the right way, and we give everybody the opportunity to work together in the right way, to really focus on that patient and what means most to them.
Yeah, I think, and one of the things, with your permission, Chair, one of the other things that worries me is, because I mean, there's a lot of people go through it, obviously, but one of the things that really worries me is there isn't a one-stop shop basically for that person. Sometimes they get pushed around from one place, and as you quite rightly mentioned, they have to repeat themselves, or things have to be repeated to yet somebody else, that what their actual needs are and what their situation is, and then it becomes messy for them, and that can detract from the time that they have available to them for the important things. Because
absolutely,
that's what our ultimate aim is, and that's what I would like to see personally.
Yeah,
and I think
absolutely.
that is most important, that person knows that that's there, ready to step in as each stage comes along. It's not going to be easy, though, I know that, but it's nice to know that you're actually starting to talk with other agencies, and I think that's the main thing, that we're starting to talk and get together on how we can do this efficiently for each patient.
Yeah, we've definitely got an opportunity, and we need to make sure we make the best use of this opportunity. There's lots of work around the personalisation agenda and how important it is to get that right across this particular pathway. And it's those conversations that we have at a really early stage around like a personalised care approach, because what's right for one patient isn't going to be right for everybody, and we need to almost, where we can, tailor the support that we offer to meet the needs of that individual. And it might change over their journey, and that's absolutely appropriate, but it's how do we try and get that right at the beginning and empower the individual, their family, the services around them to carry on shaping their care to meet their needs. Absolutely.
Okay, thank you, Jeanette. Denise?
Thank you.
Thanks, Chair. I've got two questions, one following on from what Jeanette said, and then one I was going to ask, and I was going to ask one on behalf of David Smith, but he's now joined us, so I can hand that back to him. The first one was following on from what Jeanette said, was data and information sharing. I seem to remember from health scrutiny some time ago that there was an issue about sharing medical information between different parts of the health service. The systems didn't actually talk to each other. And we know from personal experience, because we live quite close to Stockton, but we're in Middlesbrough, and we've used Stockton services, and about how the information on a member of my family was kind of transferred. And then the second question, which is different, is about the peer support network. How developed is this, and what do you need to do next? Thank you.
I think, you're right, Denise, from a data perspective, I fully appreciate that there are, we don't have a perfect solution right now. And I think some of that is probably, there's a lot of work going on around data and digital transformation to try and make sure that information flows seamlessly. We haven't cracked it, but there's absolutely, the impetus there to try and improve that. And there's lots and lots of programs of work going on around the Great North Care Record and, lots of other systems. And there's equally work ongoing on a real local level to look at how data is transferred from one organisation to another. How can we standardise? Where can we standardise? Lots of different providers will have their own information systems for absolutely the right reasons, but it's how do we try and support the interoperability across between one and the other. And what we'll hopefully try and do as part of this piece of work is build upon the regional and national programmes that are already out there working in the background on this information now. But this will give us an opportunity to look locally at what everybody has how things work now, and if there's opportunities for us locally to make improvements on that. But it's obviously not for us to work in isolation of those national pieces of work, but try and tie into them and make best use of any opportunities that arise from that as well. And I'm really sorry, I've forgotten the second question. Was it about peer support networks, Denise? I'm really sorry.
You referred in your slides to peer support networks, and I just wondered how developed they were, and what stage you're at really, and what's left to do.
So the two that I referred to in the presentation slide are very, very new, and they've come out on the back of this National Commissioning Exemplar Framework, and it's an opportunity to bring together the 4 sites across the country, so we can try and work in collaboration with each other, so we can learn from each other. So there might be something that's working really well in London, who I think are one of the sites that we could maybe piggyback on the back of or learn from, or equally if we've tried something and we thought, it's not working, we'll share that information with everybody else so we can work back and forth. And what we've asked for locally on top of that is to build a network where that's possible for our clinical leads, so they can have really similar conversations. So that's probably a bit of a national piece for the exemplar sites. But what we obviously want to do as part of the project is make sure that we've got the voluntary sector in from the beginning, and organisations obviously like Healthwatch, and just to try and better understand what support we have out there, how do we promote that in the right way, and how do we utilise it most effectively throughout our pathways, and try and make best use of opportunities that are available to us, such as social prescribing and other things. It's really piecing together a patient's journey and looking at who supports when and where, and us making sure that we've brought everybody together, so this work and the vision and the action plans that fall out of it are not just a CCG owned project, it's everybody's, and we've all got a responsibility, and if it can be co-designed and then co-owned, we can hopefully get the best possible outcomes on the back of it. And it's a really exciting project to be involved in, and palliative and end-of-life care is an absolute priority for the CCG. So we were just really, really pleased that we were selected as one of these 4 sites, because we're really hopeful that it will give us a really good push to get to where we'd like to be.
Thanks, Claire.
Thank you.
Sorry, it wasn't muting for me. It wasn't unmuting. David, you want to come in and say something? You have to unmute.
Do you want to unmute your microphone, David?
Right, sorry. One of us had to do that today, didn't we? Thank you, Chair, and thank you, Katie, for sharing that. This really is an exciting piece of work that's got the potential to really change the way that we are delivering palliative end-of-life care in this area. I've had the opportunity to speak to the regional managers at NHS England about this, and I know from their central perspective that they too are really keen that this does make a difference. There are just a couple of points that I just wanted to add to what's been shared already, though. When Craig shared his presentation last time, that was in combination with the information I shared about the hospice. And I talked about the really perilous state of the hospice finances, and Craig shared this as this work would be one of the potential solutions for delivering an answer around hospice sustainability. And within that, there's a timescale that we have got to make sure that we stick to with this. The hospice is going to approve a huge deficit budget for the next financial year. When Craig spoke last time, he talked about having some really clear recommendations by the end of this calendar year in order for commissioning to change for the 22-23 financial year. We really do need to make sure that we all work together to stick to that timescale. And I know how difficult that's going to be with COVID going on, with the ICS reorganisation going on. There's all sorts of things that could get in the way around this. But certainly from a hospice perspective, we've got to make sure that we stick to that deadline and that things are commissioned differently from the 22-23 financial year if we want to keep a hospice in Middlesbrough. And the other point I just feel I really do need to make is when we talk about where are we now, I think we mustn't underestimate just how fragile our other palliative care services are in Middlesbrough. Our community team is absolutely under the cosh. They are really struggling to keep staff, and staff are leaving left, right and centre. The waiting lists are huge. They're under enormous pressure. James Cook Hospital, with 1,000 beds, hasn't been able to recruit a palliative care consultant for a year now. There is no specialist palliative care in the trust. So when we look at the financial state of the hospice, the state of the specialist medical cover in the hospital, the current community team, we've got a huge way to go on this. We're not just polishing and tweaking a well-functioning existing service. This is a massive piece of work that is going to need really major change in a really rapid timescale, up against all sorts of barriers that won't want to see change. As soon as we start talking about moving money around the system, a lot of those doors are going to close and those conversations people aren't going to want to have. But collectively, we've got to drive this through. And I think Scrutiny can really help with this. I think having elected members check in on progress every so often, checking on actual changes on the ground can really help us on the front line trying to make these changes and encourage these conversations. Thank you.
I mean, yeah, I completely agree, David, and I think we need to utilise the opportunity that this offers us to really try and drive forward significant change. And and I'm fully on board with the fact that it's not tweaking around the edges. It's it's the whole scale system change, and probably that's why we were selected as one of the sites, because the bid that we put forward, we tried to reflect that actually the change is needed, but we have a system that is willing to work with us, and we have partners that are engaged, and we are absolutely engaged, to build on the strength of us working together to get to where we need to get to. So although it's a really difficult time, it should hopefully offer some exciting opportunities at the same time.
Okay, thank you, Katie. Thank you, David. If nobody has any questions for Katie, we'll move on. Yep. Right, Catherine, you got a short update for us?
No, Chair, it was just part of the same agenda item. That was the update that Katie's just presented.
Okay, thank you. That's I was finished with that. Then we'll go on to item number 7 is the OSB. At the last OSB meeting, there was 2 call-ins. One call-in for the bin collection, which the mayor cancelled. So that particular call-in was cancelled. And the other one was the Nunthorpe land at Nunthorpe, which is to be sold to the Plymouth Brethren. That was forwarded to the executive to look into. Now we're going to item number 8, any other urgent business. I think we have to talk about our work programme for this year. I've got a couple of things here. The work panel to look at the support for carers, paid and unpaid. And we've got the impact of COVID-19 on vulnerable adults. Because of COVID, everything has changed. So I would suggest that our work programme, the panel look at the support for carers, paid and unpaid, if that's okay with everybody. Seems to be. So we'll go ahead with that, and we'll also look at the impact of COVID-19 on vulnerable adults. I mean, that is a big topic which will take a few months, I would suggest. But shall we look at the carers, both the internal and the voluntary sectors, and see whether there might be some gaps? So shall we look at that next month, Susie?
Yes, Chair, I was just going to say, if the panel are happy, obviously I had some correspondence with the panel in relation to palliative and end-of-life care, and obviously at the last meeting we learned that the CCG is undertaking a large piece of pilot work, and therefore it may seem at this stage not great value to kind of undertake a massive scrutiny review, but obviously keep tabs and get updates from the CCG every sort of 6 months to see how they're progressing that. And obviously David alluded to the fact that we've got some discrepancies within James Cook Hospital and the fact that we don't have a consultant. I think it's just a case of scrutiny and ensuring that we keep that in mind, and ensuring that we get regular updates from the CCG about how the project and the pilot is running. So obviously it's now a case of looking at the next work programme, and I know that a few months ago we did look at this and outline that we might look at the support that we've got in place for carers, paid and unpaid. So if the panel's in agreement, I'll speak with Eric and find out who the appropriate officer would be to invite to the next meeting to kind of give us an overview of what support we have internally, and then from there we'd look at the external support that we have to see whether there's gaps and where Scrutiny can make an improvement, if that's in agreement with you, Chair, and the panel.
Well, I think it is a good subject, especially at this time, because I'm sure the carers are overworked and possibly underpaid as well. But that's another point. If the panel agrees, we'll look at the carers, support for carers. Is anybody disagreed? Denise, you like to say something?
Yeah, just as part of that, could we also look at the financial support? And that might mean bringing in somebody from our benefits team to talk about what is available, because there are huge gaps in uptake for the benefits that are available for people, and I'd like to see that, you know, at least covered within this. So thanks.
Yes, thank you. I know we have a shortage of carers, so it is a good subject to discuss. So on our next meeting, Susie, we'll discuss that. Yes?
That's fine, Chair. Thank you. I'll organise that for you.
Yeah, and everybody's in agreement. And I think that is us for today. Nobody else, anything else to say before we say goodbye? Thank you all for your attendance. Thank you for your input as usual. It's been very much appreciated. And thank you to our guests as well. And thank you, Susie.
Thank you.